So hello everyone, I'm very happy to be here with you to speak about this interesting program about cancer immunotherapy and the change in paradigms in cancer immunotherapy. So what we're going to do in this program is first of all give you an overview that I will give you in 30 minutes, and then you will get a series of different interesting talks about predictive biomarkers and so on that you will get in the subsequent part of this program here. So what I'm going to start with is to give you an overview of the cancer immunotherapy that we are speaking now. I'm Dr. Escudier from Gustave Roussy in the genitourinary group in my institution, and I've been involved in immunotherapy for many years now. So this is my disclosure. So just to go back to what we do in cancer, we have done a lot of different approaches to try to improve the cancer we see in our patients here. Of course, the first step has been surgery, and if you go to old days, the first surgery for cancer was done in 1846. Then the introduction of radiotherapy came at the early 90s, and in 1901 came the first machine on radiotherapy here. And then the concept of chemotherapy came in 1950, and of course you know that we developed a lot of chemotherapy, which of course is not targeted to something special, but try to stop the growth of tumor here. And recently, in the past 20 years, I would say, two new concepts arise and came to our new therapy for cancer here. So the first one is what we call targeted therapy. So the principle of targeted therapy is to try to find a target in some tumor cells and target these specific targets to try to stop the growth of the tumor. As an example, we worked on HER2 for breast cancer, on c-KIT for GIST, on VEGF for tumors who express VEGF. So that's what we call targeted therapy. The concept came in 1997. And of course, due to the discovery of a lot of biological new concepts, this targeted therapy became very popular at the beginning of the 2000th century, of course. So that's the first new concept which came here through ages. The second concept came not to target the cells, the tumor cells, but to target the host itself by trying to make the host more able to fight against cancer. And as we know, we have and we develop all over our life some abnormal cells that the immune system is able to get rid of. So the question is, why don't we get rid of all the tumor cells? And the question is that our immune system sometimes is not able to do that. And targeting the host and the immune system has been an idea for many years now. And if you go back to this old approach of immunotherapy, which we call the toxin from colase, that we use to try to develop an immune reaction against a tumor, it was used in 1899. So quite a long time ago, the idea that we could use the immune system to fight against cancer was developed here. And as you can see, if we inject the toxin in some tumor, we can, in sporadic cases, of course, unfortunately it's not in every case, we can see some decrease and some tumor shrinkage, which in these patients was very dramatic here. Does it go through PD-1 or PD-L1 interaction? We still don't know, of course, but that might be one of the ways this toxin has been acting here. And a lot of approaches about immune therapy has been done through the age. And of course, this is due to the fact that the immune system is made by different cells within the tumor environment. Some are good, some are bad, and you can see here the different players of the immune system. Some will bring the antigens to the immune system, which we'll call the presenting cells. Some will be good cells, which are activated T cells. Some will be bad guys. And of course, the tumor suppression and tumor progression will be a kind of balance. And getting a good balance in terms of tumor suppression, good guys, will make the immune system able to act against cancer cells here. So let's see about what can be done in a video which will give you a good idea about what is the immune system, how the immune system can work. And so you will see this nice video now.
The main main functions of our immune system are to monitor tissue homeostasis, protect against pathogens, and eliminate damaged cells. Research in recent years has shed light on the relationship between cancer and the immune system, and has positioned the immune system as a crucial regulator of cancer development. Cancer cells can avoid detection and destruction by immune cells. This can happen through making detection more difficult by reducing the expression of tumour antigens, expressing proteins that induce immune cell inactivation, and inducing cells in the microenvironment to release substances that suppress immune responses and promote tumour cell survival. While the immune system is important for recognising and eliminating tumour cells, it also plays a critical role in tumour progression. This dual role of suppression and promotion is termed immunoediting and consists of 3 phases: elimination, equilibrium, and escape. During elimination, most cancer cells are destroyed by the immune system. Certain tumour cells that survive immune destruction enter the equilibrium phase, which is characterised by immune resistance. The escape phase is the final step, where immunologically resistant tumours grow and establish an immunosuppressive microenvironment. As a result of this process, immunotherapies that stimulate the immune system or counteract signals produced by cancer cells that suppress immune responses have been highly sought after. For example, immune checkpoint modulators help stop immune checkpoint proteins from suppressing immune responses. This allows the immune system to become more functional, increasing its ability to destroy cancer cells. A second method is immune cell therapy. In one strategy, T cells that have infiltrated a tumour are collected, and those that show the greatest recognition of tumour cells are selected and grown. They are then activated by cytokines and reinfused to help shrink or destroy tumours. A third approach is antibodies. For example, antibody-drug conjugates link antibodies to a toxic substance that is delivered to a cancer cell when the antibody binds to it. Other antibodies induce apoptosis or recruit other immune cells to destroy the target cell. Ultimately, these immune-related methods continue to show promise in the medical management of cancer.
Of course, the anti-tumor effect is a dynamic process. It's not a single process where you have one cell acting against tumor cells. And you can see on this cartoon that we have different steps in terms of what happens when you go to the immune therapy system here. First thing that you have a relapse of cancer cell antigens, which is of course the first step when you have cancer death cells, where the antigen is released in the microenvironment. This antigen, of course, is not always known, but this antigen is supposed to be presented by what we call cancer antigen presenting cell. The main one being the dendritic cells, the antigen presenting cells here. Then based on this presentation to the immune system, we should have a priming and activation of the T cells. That's what we call the interaction between antigen presenting cells and T cells activation here. These T cells, which are activated now, should traffic and migrate to the tumor cells. And then in this microenvironment, this infiltration of T cells is going to have, obviously, if it works, an anti-tumor activity against the tumor cells here. And that's what we have in terms of killing the cancer cells by the immune system with this dynamic process, where we have first release antigens, presenting the antigen, then activation of the immune system, and then the T cell activated become killer cells, which are going to kill the cancer cells here. And that's the reactivation we try to get when we use immunotherapy with what we have done for many years now. So what we have learned in the past, I would say 10 years, is that we have some very important receptors. We call that the immune checkpoints, which are both on the part of the T cell, but also of the antigen-presenting cells and on the tumor cells here. And these immune checkpoints have a very important role, both in terms of inhibitory or activating effect here. This is an example here of what we have between the T cells and the antigen-presented cells. The antigen here is presented by the APC here to a T cell receptor here. And then we have a second signal here, which becomes now a co-stimulation between CD28 and B7 here, which is an important part of the activation of the T lymphocytes here, and which is a required step for having this here. This activation is also then controlled by what we call inhibition of T lymphocytes. Why is it like that? Because the immune system is initially mostly done and built to fight against viral bacterial antigen here. So what has been done with the human system is that we, at a certain point, have some inhibition of the immune system just to avoid to have permanent activation of our immune system. And in addition to what we have activated signal, we have negative signal here, such as PD-1, PD-L1 interaction, which is one of the negative signal here, or CTLA-4, B7, which is another negative signal here. So these negative signal are going to make a break on the immune system. And that's the balance between activation and inhibition, which is going to explain what's going on with the immune system here. And of course, more we understand the immune system, more we understand the way it's activated and then inhibited, more we try to get a better way to use the immune system to fight against cancer here. So if you look now at what we have in terms of acquired immune resistance, which is of course something that we have in most of our cancer who develop cancer, patients who develop cancer here, we initially have innate immune resistance when we have PD-L1 and PD-1 which are expressed on the tumor cell and the T cell. So that's something which happens. In some tumor cell you have expression of PD-L1, in the T cell you can have expression of PD-1, and if you have both these expressions, then you have immediate, what we call innate immune resistance to immune system. So these are tumor cells which are going to grow whatever you do, except of course if you can break and stop this interaction here. You also have what we have adaptive immune resistance, which means that initially we have an active system and we have T cell activated by presenting the antigen to the immune system. But then, because of some pathway which are going to be activated by the T cells, like STATs and so on, you will have expression of PD-L1, secondary expression of PD-L1, which is going to be induced by the evolution of the cancer, which is going to stop the activation of the immune system and then to avoid that the immune system is going to get rid of the tumor cell. So two different mechanisms. One is innate, which means that it's from the beginning of the story. One is induced, which we call adaptive immune resistance, which is mostly coming with most of our cancer here. So this resistance mechanism to immune checkpoint inhibitor are of course something that we would like to try to get rid of. And this is what we call the cancer immunogram, which means that we have different ways we could act to try to re-stimulate the immune system and to try to fight against this mechanism of resistance to the immune checkpoint inhibitor. And this is different way to act against this problem of resistance, and of course to try to induce activation and effect of immune system here. And you have the different factors which are important in terms of how immune system is going to work here. One, of course, is the tumor load, and you understand that the antigens are very important. And the mutational load, so more you have antigens, more it seems that you can have immune system activation. And this mutation load is different from tumor to tumor, which might probably explain why some tumors are more immunogenic and some tumors are less immunogenic. So this is one player here. Of course, the lymphocyte count is important. If you don't have lymphocytes, you cannot stimulate your lymphocyte because you have not enough lymphocyte to act against tumor. The intratumoral infiltration of the T cell is also important. Not only you need to have lymphocyte, but you need to have lymphocyte within the tumor. These T cells within the tumor are going to get activated, what we call intratumoral T cells, and they are very important here. Then you have the PD-L1 and the other checkpoint inhibitor. If you can get rid of PD-L1 or if you can block PD-L1, then you might reactivate the immune system. You also have some very important inhibitors, which are, like an example, interleukin-6, C-reactive protein or others, which are inhibitors of the immune system here. If you can remove IL-6, CRP, and so on, TNF-alpha, and so on, from the microenvironment, you can also reactivate the immune system here. And then you have some other probably important factors, which are, like an example, glucose activation, and you need glucose in the tumor cells to grow the tumor. So if you can decrease the glucose level in the tumor, etc., this is also some important here. And finally, if we go back to the first part of the immune system, presentation to the cells is important, as I told you before. So MHC expression, which are important factors to be able to express and present the antigens to the immune system, is important, as well as interferon gamma, which is one of the important cytokines, which is part of the immune system activation I will see later on here. So let's go now to the general concept of PD-1, PD-L1, which of course has been the first important cause signal to be activated in cancer cells here. So this is, as I told you before, a very schematic presentation of what's going on with the immune system here. First signal, antigen recognition. Of course, you need to have an antigen, but this antigen is presented to the T cell, and you have the first step here. And then you need the co-stimulation, which is signal 2, which are important one to be part of the immune system part. And some of these co-signals, signal 2, is positive. Some of these co-signals are negative. And many of these negative second signals promote tolerance to the immune system here. Of course, co-stimulation is key here, but you have to know that some are positive and some are negative here. So this is the first step. You can see positive signal with antigen recognition here. Then, of course, you have another positive signal here, but you have a negative signal here when you have negative co-signal, which is going to make a break on T cell. As an example, PD-1, PD-L1, which is a negative co-signal here. And this is some of the co-signal which have been described in the past, I would say 10 years here. PD-1, PD-L1 is now more than 10 years knowledge, but we have some new concept coming on, and you can see that some of them are probably not yet described, but we have inhibitory and positive and stimulatory co-signal here. So that's certainly PD-1, PD-L1, one of the most important one, because we know exactly what's going on here. And also we know that PD-L1 expression on the tumor cells is probably one very important prognostic and predictive signal for activity of this interaction between PD-1 and PD-L1 here. So that's something that you have to know. CTLA-4/B7 is also very important here, which is interesting between the B7 is both activated by CD28 and inhibited by CTLA-4. So that's a very important signal here, co-signal, which can be on the activated or inhibitory side here. So let's go back to this cartoon here. So what do we get when we have activation of the immune system here? So antigen-presenting cell or tumor cell are presenting an antigen to the immune system here. So it might be APC with a virus or a microbe or a bacteria, of course, but it can be tumor cells with antigen from the tumor cells here. Activated T cells come now because the T cell is recognizing that something wrong is going on here. So what's going to happen here? So initially, the immune system is activated. We'll have production of interferon gamma and other cytokines. We'll have proliferation of T cells. And we have cytotoxicity against this APC or tumor cell presenting here, which is a main mechanism for fighting against infection, as an example here. So then the negative co-signal are going to come here. And the idea from the host immune system is avoid having a permanent activation of the immune system here. So as I told you before, PD-1 is one of the main co-signal which is going to make a break on the immune system here, PD-1, which is going to be important here because it will link with PD-L1, of course, if it's expressed, and it might be expressed in some tumor cells, in many tumor cells, in fact. And due to this interaction between PD-1 and PD-L1, negative co-signal, as I told you, this induced proliferation, cytokine activation, and cytotoxicity are going to go down, and then the immune system is going to become exhausted. That's what we call exhausted T cells. Immune response is going down, and of course, proliferation, cytotoxicity, cytokines like interferon gamma is dropping down. So why do we know that PD-L1 is important in tumors? And that's one of the first evidence that PD-L1 expression is important. That was reported in 2004 by the Mayo Clinic group, looking at PD-L1 expression in kidney cancer here. And you can see that PD-L1 is expressed in many RCC here. And interestingly, what has been shown by this group is that PD-L1 expression is a negative prognostic factor. The more you express PD-L1, the worse the outcome is. And that's probably due to the fact that the immune system is not able to fight against this bad tumor here, and explaining why RCC expressing PD-L1 have a poor outcome. And that's obviously not only in the localized tumor, but also in the metastatic tumor here. So that's what we have now. So we have an exhausted immune system, which is unable to fight against cancer. And that's why most patients develop cancer, and cancer grow and grow and grow. So the idea was to try to understand, because of this co-signal, can we block this co-signal, and can we restore the immune system here? And that's what we do when we block the interaction between PD-1 and PD-L1 with an antibody against either PD-1 or PD-L1. Just explain you why you can use both PD-1 or PD-L1 antibody in terms of this desactivation of the immune system. Both sides are working, and probably very similarly between PD-1 and PD-L1 antibody. The main difference is that we also have PD-L2, PD-L3, which are not blocked by PD-L1 antibody alone. But that's something that you have to understand. That's just blocking the interaction between PD-1 and PD-L1 between T cells and tumor cells here. And then we restore the activation. We restore the activity against the tumor cells, and of course we are able to restore cytotoxicity and immune sensitivity of the tumor cells. So as you know, I told you that this is not only the T cell and the PD-L1 expression. Mutational load is important here. And as you can see on this slide, which is a very important paper here, different tumors are different mutation rates here. And going from the left to the right, you can see on the right side some tumors which have a very high mutation load. And of course, some of these tumors are more sensitive to the immune system here. So that's a very important concept too, and maybe increasing the mutation rate might be a way also to increase the activity of the immune system here. And multiple factors are going to contribute to the generation of activated T cell immunity and tolerance. And you can see on this slide too, which is going to be some of the factors of the tolerance and some of the factors of the immunity. And that's going to be a kind of equilibrium and balance between these two factors to try to use the best we can the activated T cells and avoid tolerance. That's something that we have to avoid for fighting best to cancer here. So one of the questions now is, which are the immune biomarkers? And of course, that's one of the important part of the work which is actually ongoing in many places, many institutions, to try to understand which are the predictive biomarkers here, which are the factors which are going to explain why immune system is working, why it's not working, how we could do better here. And of course, we have different parts of the expression here. PD-L1 expression in the immune system is important, both in tumor cells but also in T cell here. The blood vessels are important too, because if you don't have trafficking to the tumor cells, if T cells cannot go to the tumor cells because of vascularization, then the immune system is not going to work here. As well as we need antigen stimulation and presentation and activation. So we need T cells, lymph node probably, which are going to gather T cells, which are going to be able to activate the immune system. So these are different parts of the immune biomarkers which we are going to try to look at. We are going to try to understand better to predict which are going to be the factors to predict the good outcome for our patients here. So the final question for me is how can we modulate responses to immune system here? And that's something which is very important here. How can we do better than we do actually, as an example with PD-1, PD-L1? And as you know, PD-1 and PD-L1 is actually involved in many tumor types with some good results in many solid tumors and even hematological malignancy, but we want to do better here. And we have different ways to increase the activity of this blockade here. So one way, of course, is to use another checkpoint inhibitor. And we have anti-CTLA-4 as one of the ways to use it, but we have a lot of other checkpoint inhibitor antibody which are going to come in the future, which are going to be in clinical trial in phase 1 here. We can also induce and increase trafficking of T cells by using some cytokines and trying to do better. We can use anti-VEGF therapy, which is very important both in tumors which express VEGF like kidney cancer, but also by increasing the infiltration of T cells by allowing better penetration of the T cells into the tumor here. And finally, by co-blocking PD-1 and PD-L1, there is some way, to try to combine PD-1 and PD-L1 blockade, which is also a way to do. Of course, we can also combine with chemotherapy. We can also combine with activated agents, targeted therapy, and that's a lot of approaches which are actually a way to try to modulate responses to checkpoint inhibitor here. So with that, I want to thank you. I hope that you will understand better the immune system now and will be able to follow the next session. Thank you very much.